many people here in person, and I know we have quite a few people joining us on Zoom as well. So my name is Angela Hobson, and I have the distinct pleasure of being the Associate Dean for Public Health here at the Brown School. And I also have the distinct pleasure of welcoming all of you to our first installment of Public Health Speaker Series for this academic year. And we're really delighted to have Meredith Rosenthal with us here from Harvard. And I'm going to introduce another faculty member who's going to introduce her in a moment. But just a few logistic pieces is that we go from 12 to 1. We do know that some of you have class at 1, so if you need to scoot out early, that's totally acceptable. The presentation is usually around 35, 40 minutes, and then we have time for questions and answers at the end. We'll field questions from folks here in the crowd, and we'll also keep an eye on Zoom and see if there are any questions that come in from folks on Zoom as well. See how well we can juggle the hybrid approach here. Okay, so I'm going to introduce one of our newest colleagues here at the Brown School that we're really excited to have join us. Her name is Meredith Shields. I said Meredith. I'm the second person to do it. Oh my gosh. You do look like sisters. Morgan Shields, she's an assistant professor here at the Brown School. Morgan researches the quality and accountability of behavioral health care. Her work seeks to identify implementation strategies to improve the use of evidence-based practices with a focus on patient-centered care and equity. She is particularly focused on identifying policies to motivate and support quality improvement. She is one of few people studying the quality of inpatient psychiatry, and her research identifies disparities in quality performance at the Veterans Health Administration, and that's led to internal investigations by the Deputy Undersecretary for Health and Organizational Excellence. And I know some of you are familiar with Morgan because she is teaching research methods, and we're really excited to have her in that role, and also the other courses that she'll be teaching in the future too, and really excited about her being a great mentor to our students here. And she has a little bit to say about that because our guest for Public Health Speaker Series has been a great mentor to her. So without further ado, I'm going to pass it over to Dr. Morgan Shields.
Great. Thank you, Dr. Hobson, for your introduction, and thank you everyone for being here. It is my honor to introduce Dr. Meredith Rosenthal. I will take any opportunity, as anyone who knows me knows, to sing her praises, both in regards to her academic brilliance and her admirable character. Dr. Rosenthal is the C. Boyden Gray Professor of Health Economics and Policy at the Harvard T.H. Chan School of Public Health, Faculty Chair of Harvard's Advanced Leadership Initiative, Director of the PhD Program in Health Policy at Harvard University, and is also a member of the Massachusetts Center for Health Information and Analysis Oversight Commission. Her research examines the design and impact of market-oriented health mechanisms, with a particular focus on the use of financial incentives to alter consumer and provider behavior in ways that promote high-value care. So this is care that is appropriate, patient-centered, and equitable. I feel that I am uniquely positioned to emphasize how rigorous, coherent, and impactful Dr. Rosenthal's work has been. I once read every single empirical and viewpoint paper she wrote, analyzing them for themes, common themes, and contradictions. And this was a task to help support her expert testimony in class action lawsuits related to the opioid epidemic and outsized market power by health systems and pharmaceutical companies. Her work is tight, defensible, and often either explicitly focuses on equity or at least translates findings for what that might mean for vulnerable patients with the least power. She is a model for how one might think about maximizing their professional academic position in ways that both generate actionable evidence and actively translate those findings through sitting on local boards, consulting with leaders, and testifying in litigation cases against powerful players. But I and many other students and junior faculty have benefited the most from Dr. Rosenthal's mentorship, sponsorship, and unconditional acceptance. Indeed, Dr. Rosenthal has been a very special mentor and friend of mine for almost a decade. I first met her when she was Dean for Diversity and Inclusion at the Harvard Chan School. I was seeking support for a conference that I was developing focused on the experience of quote unquote otherness. And Dr. Rosenthal not only supported the conference, but empowered me as a leader and then eventually as a scholar. She supported my research and training from the very beginning, even though at the time I was in a completely different department from hers. When I moved to a new school for my PhD program, she would drive out there. We would go to restaurants, museums, movies. She served on my dissertation committee, met with me weekly. She still meets with me weekly on the phone. She was my cheerleader, provided material support, financial support, helped me pay for movers, things like that, and made me feel like she was my safety net, that I would be okay no matter what, but also that I deserved everything good. Over the years, Dr. Rosenthal has been perhaps the most important person in my life, and that is a fact and not an exaggeration. And I do share credit with her for any career success I have, and absolutely not the failures. So Dr. Rosenthal is a model for how to occupy space in academia with integrity, generosity, and a deep embrace for the ideals of diversity, equity, and inclusion. It feels full circle to be the one hosting Dr. Rosenthal, driving her places, providing her with a bedroom and food, given all the many times she did the same for me when I was a trainee. So I want to thank Drs. Tim McBride and Karen Joyt-Maddox for facilitating such a warm and energizing experience for Dr. Rosenthal. And with that, I welcome her to the stage.
Let's see. Green. Great. Can you all hear me okay? I'm not sure about the two mic thing. First of all, thank you so much, Morgan. I'm really touched by that introduction, and it means so much to me the way Morgan has been welcomed here by all of you. And I know you have a great new colleague and professor, and I'm just excited for all the good things. And what a wonderful visit I've had over the course of these 2 days. Thank you all for this incredible welcome. I'm so jealous of your beautiful campus. If you've ever been to the Harvard School of Public Health, you'll know what I mean and why. And the intellectual vibrancy of this community is really, really striking. So I know this is a very exciting time on campus, particularly in the public health space. So it's a great time for me to be here. So the project that I'm going to talk about today is actually a set of projects. And I just want to start off by noting that I think it's sort of appropriate that this talk is about cascades, and it's really a set of cascading research ideas that I've had the wonderful pleasure of working on with a very big research team. We'll list sort of all the names of the people involved in the research at the end of my presentation. But first and foremost, I want to give credit to Ashani Ganguly, who is a general internist and health services researcher at the Brigham and at Harvard Medical School, has really been at the forefront of this work. And I had the wonderful pleasure of meeting her when she was a trainee. And we had just started this work, and she really picked it up and ran with it. So all credit really goes to her. And one of the really interesting things about Ashani and the work you'll be able to tell is she has training as a journalist. She took time off to be a journalist, and she writes a column for the Washington Post. And so she's always thinking about translating the work, not only for people practicing at the front lines of medicine, but also for the general public. And so the title of the talk comes from her. She also has small children. For those of you who have ever had small children, you might recognize this from, there's a children's book called If You Give a Mouse a Cookie. And it's essentially a book about cascades. So Shani came up with this title that really fits the work so well. And where it all started, for me at least, was back, and I think it was 2013, when the Choosing Wisely campaign really got rolling in the US. There had been these lists that originally primary care societies had developed to identify low value healthcare services with the idea about trying to start a conversation with physicians about cost control in a way that would be acceptable to people in the profession. And in 2013, those Choosing Wisely list expanded from primary care into other specialties. And a number of my colleagues, both at Harvard, but also at Dartmouth, were very interested in whether these lists would provide a real opportunity for engaging the people who make so many of the important decisions in our healthcare system that drive costs, really engaging a new conversation around cost control. So in 2014, we looked at all the lists that had come out. Then I think there were something like 25. Now there are more than 100 of these lists of low value services to try to understand what it was that specialty societies in particular were identifying as low value. And that was really the start of our research agenda. And I won't tell you sort of about all of what we found, but one big takeaway we had was when you started to look at the list, and if you went into, let's say, Medicare claims data, where a lot of our research was ultimately done, and identified all of the instances of low value care based on these lists, and added it all up. First of all, it was a very difficult thing to do because low value services were often described in a way that made it very hard to translate into something very specific, because the recommendations often say, don't do an EKG unless there is a medical history of X. And of course, you can't see a medical history in claims data. But what we found is, when we made relatively conservative but reasonable assumptions about how to translate those words into identified services, we found that the spending on low value services was just tiny. And we thought to ourselves, well, a couple of things might be going on. First, maybe the professional societies are just avoiding naming the things that are really profitable as low value, because that would be inconsistent perhaps with the people they represent. But also we thought, well, it's not so much the MRI of your low back that we worry about. It's what happens after the MRI. And so that really was the beginning of the idea that we had to try to understand better what happened after low value services. And in the course of the talk, and these slides come from Ishani, and they're a compilation of a set of studies that I've been co-author on some of them, but not all of them. But you'll see, we'll define low value care. But I as an economist, and the great thing about this work is it's really an interdisciplinary group of folks, prominently featuring physicians, because there's so much clinical content here, but also economists. And so low value care to an economist is a service. Thank you so much. Oh, wow. And I thank you. That's great. That's perfect. No styrofoam cups. It's essentially a service where the expected benefits are lower than the expected costs. And of course, a low value service in expectation is not always after the fact something that we would say for an individual patient they got no benefit out of. And so that'll be part of, no doubt, the questions that you'll have in your mind is, to what extent do we feel confident that these low value services really should not have been delivered, or maybe they just need to be targeted better. So low value care often in the context of Choosing Wisely list has focused more on no value services than low value services. So a no value service is essentially a service where the risks exceed the benefits, where a clinician would say we should never do this because the risks actually outweigh the benefits, ignoring the economic costs. See if I can make this. Maybe not. Maybe I'll just do these guys. When in doubt, use the mouse. So if you give a mouse an EKG, then the logic goes, the doctor may feel compelled to get a stress test to go with it, which is at the end of this cascade. And so the idea is people get EKGs which are cardiac tests in a number of contexts, and EKGs for patients who do not have cardiovascular disease and do not have certain risk factors are on the low value care list. But they're very inexpensive. They're easy to do. And so oftentimes healthy patients get them at, for example, something like an annual visit. And so in the logic of a cascade like this, if a healthy patient gets an EKG and then there's a borderline result, then the physician may feel compelled to do another test. Maybe it's a lab test, and then the patient will get the results of that lab test, which are ambiguous, and the doctor and patient will spend some time on a telephone visit. And then the doctor will have to add notes and call in an order for another test. In this case, the end of the cascade is a stress test. And many physicians can tell you about instances of these kinds of cascades happening. A healthy patient with a borderline result that then causes the patient to get another test, even when the physician who ordered the original test is perhaps not worried about the borderline result. It reminds me, one of the first people I worked on with this was Tom Sequist, who is now the chief medical officer at Mass General Brigham. And he talked about, he had a job at Atrius Health, which is a medical group in the Boston area, where he was in charge of quality improvement. And, you know, he would look at data and would find, for example, people ordering PSA testing on people over the age of 80, where it's really not recommended. And he had a doctor come to him with a dilemma. He'd ordered a PSA test and it exceeded the limit where a biopsy was recommended, but the doctor felt like the biopsy would be unethical to do on this older gentleman who had other health complications. And Tom said, "So why did you order the PSA test?" And so often what we hear from physicians is that these cascades, they have a momentum of their own, and that physicians find themselves in the middle of the cascade, wishing they had not gotten to the top of it. And so some of the work that we've done in this area has been to try to understand a little bit more about the physician's point of view on cascades. And so what we know about cascades is that they're highly prevalent. There have been various estimates to try to understand how frequently an imaging test leads to a follow-up test because, for example, of an incidental finding. And some of the work that we'll talk about here is related to incidental findings. But these estimates they're very rough, I can tell you. This is a very hard thing to do in population level data. It's much easier to do, for example, in electronic health record data, where you could really understand patient history and that kind of thing. But clearly unnecessary services, low value care is prevalent. And around the same time we started our research in 2014, there were a number of other researchers who went on to document low value care, Aaron Schwartz being the one I think who's contributed most in this area. So low value care is clearly a big issue. And incidental findings, unexpected results that had nothing to do with why the original test was done, those are also quite common. About 1 in 4 imaging tests leads to an incidental finding. And then the question is, what do you do with those incidental findings? And ultimately, what are the costs and benefits to patients from following up on incidental findings? So at a high level, we know that these kinds of cascades have the potential to cause harm to both patients and to physicians in a variety of ways. And I'll use harm in the way we defined it in some survey work, which could be about crowding out other useful other uses of the physician's time. For example, if physicians spend a lot of time following up on incidental results, that doesn't allow them the opportunity to see other patients. So it can be about time. It can be about anxiety for patients. How many people have ever gotten an unexpected lab or imaging result and it just shows up in your medical record and you think, oh my gosh, what's going on? And I think one of the sort of interesting things about the fact that many of us have access immediately to our test results without interpretation is that we get to feel that anxiety earlier and wait to follow up with the physician. So there are clear consequences here, even if there is no further testing or intervention. But this conceptual model, which was put together by a physician at Sloan Kettering, Deb Korenstein, who became a co-author because her work sort of came together very much with ours, was thinking about a conceptual model for the way an initial overused service can lead to harm by causing downstream services that again take time, cause anxiety, that lead to a general mistrust of the healthcare system, which I think some of us end up feeling after chasing one of these incidental findings, but also long-term health consequences. And in the extreme, of course, the kind of interventions that people get from low-value testing, they can be very harmful, even fatal. So our team has been working on trying to get a better sense of in what context these happen, what is driving low-value care, and how we can ultimately intervene. And I haven't been involved in the intervention work, but Ashani and some of her colleagues at the Brigham have developed some interventions that really came out of the physician survey that we did early on to try to provide better decision support, both to physicians and to patients, which is really what was identified in that survey as being most effective. But we can sort of talk about other perspectives on that as well. So the first piece of the work that we were able to move forward, we got an R01 to start a lot of this work and look in the Medicare population in particular, but we also had this opportunity to work with the American College of Physicians. Those are for internists and geriatricians, outpatient docs, largely in the Boston area, at least. These are sort of the biggest group of primary care physicians that we have. So we had a national survey sample from the American College of Physicians where we were able to ask them in particular about incidental findings, because in a survey, of course, you want to be able to define terms a little bit more clearly than just low value care, because we'll all have a different idea about what low value care means. But incidental findings are a little bit clearer. And so among other things in the survey, we put together some clinical scenarios. And when I say we, I would say the physicians on our team put together some clinical scenarios about incidental findings to ascertain what physicians would do in a particular context. So you have a healthy 60-year-old man with a chest x-ray and there's a finding of a lung nodule. And there are specific guidelines about following up on these lung nodules. And the guidelines say in this case, so this is an abstraction, of course, that no further action should be taken to follow up on this lung nodule. And we asked physicians if they would repeat the chest x-ray, if they would send the patient to a subspecialist, or if they would do nothing. And more than half of respondents said they would take action on this lung nodule, despite the guidelines to the contrary. And I would also note, we use some validated scales to look at characteristics like risk aversion and cost consciousness. And we did find two things that predicted whether physicians would follow up on the lung nodule. One was the extent to which, based on this validated scale, they were cost conscious. And physicians who were more cost conscious were less likely to follow up. Physicians who were less cost conscious were more likely to follow up. US trained physicians would be much more likely to follow up. And I don't know if any of you are physicians, but when I've had visitors come from other countries, particularly places with single payer healthcare systems, and they go and either shadow or practice here in the US, they are amazed at the use of technology and the extent to which physicians are much more readily taking that next step. And so this is very consistent with that impression. When we asked them about what happened, this is in the physician survey, what happened with these incidental findings and the cascades that happen, more often than not, the cascades essentially lead to nothing. But at the top of the list, many incidental findings do relate to the need to communicate with patients. And so you can see in the shaded bars here, the darkest blue is at least weekly, that an incidental finding causes you to have to, for example, have a phone call with the patient to explain the finding. And then the next shaded amount is monthly, at least several times per year, and never in the rarest incidence of the very light blue there. And physicians, they described that most of what happens from these incidental findings is a need to communicate or repeat the same test. More rarely is a new diagnosis, a new treatment, but still these kinds of incidental findings do happen to almost all of our respondents in a given year. And in many instances, they lead to some additional actions on the part of physicians. The extent of harm is really in the bottom 4 bars, where no clinically important or intervenable outcome happened in the majority of time. Actual patient harm happened relatively late, rarely, and physician harm defined usually in terms of concerns about litigation, use of time that was deemed to be inefficient was more common, but still relatively uncommon. So the survey suggested that these incidental findings, they do happen quite a lot. Generally, their burden is relatively low, but the clinical scenarios suggested to us that there's a lot of uncertainty about what to do, even when there are guidelines, and that this sense that we had gotten anecdotally, both from the clinicians on our team and from others, that physicians often feel conflicted about an incidental finding, even when there are guidelines, certainly comes through in the survey. Just notably, when we looked at the physician characteristics that predicted more physician identification of harm, physicians in rural settings seem to be really more concerned. I think that suggests that's where the opportunity costs are higher, where the time constraints, the resource constraints are more extreme. And so chasing an incidental finding that is not ultimately going to improve patients' health is seen to be more of a problem in these contexts. And in addition, again, in a validated scale about risk aversion or discomfort with uncertainty, physicians who in general were uncomfortable with uncertainty, they were more likely to have identified that they chased down these incidental findings, spending time on something that ultimately didn't benefit their patients. And so in this very cool diagram that Ishani made, you can see sort of the flow of actions from left to right. So in the first part of the grid, it's who ordered the test. Another generalist or me, again, these are primary care physicians in the outpatient setting, or a specialist. The next action is where was the initial test done? Inpatient in blue, outpatient in yellow. What was the initial test? Imaging test, blood test, or other. Why was the initial test done? Diagnostic, preventive, existing condition. Was the initial test clinically appropriate? Again, this is based on the judgment of the respondent. Yes, 2/3 of the time. No or not sure, 1/3 of the time. Given what you would imagine the bias in a survey to be, I find it quite striking that that anyone would say no, but I guess in some cases they're talking about another physician. And then did the cascade uncover anything clinically important and intervenable? Yes, about 2/3 of the time. No, about 1/3 of the time. Did the cascade cause patient or physician harm? Again, defined both in terms of physical harm to the patient, but also in terms of opportunity cost to both. About 83% of the time, the answer was yes to that. So this gives us a bit of an understanding of how these events are occurring. And I think one of the most striking things to me is really that 1/3 of the initial test, not the incidental finding, but the initial test that led to the incidental finding was deemed to be low value. And so that's really where the idea of cascades come in. When the initial test, there are incidental findings for all kinds of recommended tests. You break something, you break a rib, you get a chest x-ray and they find a lung nodule. That's a bit different than when you get a screening x-ray that's low value to begin with, and you have an incidental finding. And so we were really most interested in these cascades that start with a low value service. Those are the results from the survey with a little bit more information that physicians reported that the cascades were often pursued not because it was in their best clinical judgment that patients should get additional care, but that they were worried about the perception of their colleagues about whether they were taking appropriate steps. So they said that it's the norm in my practice to follow up on these kinds of results, or concerns about litigation was another significant response about why low value care was pursued. Another doctor advised it. So maybe the physician is in a larger group and consulted a colleague about the test. And then last but not least is the patient asked for it, which was in the minority of cases, but about a quarter of physicians reported that they followed up on the test because the patient asked for it. And when it comes to low value care, this has been a common response that physicians raise concerns that if in fact they were to follow these guidelines that recommend not following up on care, that patients would leave, or potentially it would put them at risk for litigation. And so this patient perception piece is an important thing for us to understand, to the extent that it's a driver, although you can see it is not as important as the sense of being in a larger ecosystem that is pushing physicians toward these kinds of actions. And it's interesting, I was looking at some results from outside the US about low value antibiotic prescribing, and in some really interesting qualitative data that was done in the National Health Service in England, they found that the #1 reason that junior physicians prescribe antibiotics when they're not indicated is because their senior colleagues do. That sets us up in some ways to think about interventions, because clearly peers and senior mentors matter. For those of you who've trained in the healthcare system, that traineeship and the influence of your senior colleagues is really critical, of course. So this is towards the end of the survey, thinking about, what could we do better, asking the respondents about how we could actually intervene on cascades. And we look separately at the senior physicians, the attendings, and the trainees. And I think very interestingly, the responses that get the most approval here really have to do with decision support. So point of care decision support about what's the right next step to take on this initial test. But malpractice reform is on the list as well. That's often top of mind for physicians. The evidence on the extent to which, and I know some of you in the audience know more about this than I do, malpractice really does change practice patterns are somewhat more mixed, but it is very much top of mind for physicians in the US. And very low on the list are value-based payment models, which of course a health economist would know and love. But physicians, attendings in particular, the senior physicians really give that very little chance of success. Trainees seem to be perhaps a little bit less skeptical. And so these findings really motivated the work that Ashani and her colleagues have been doing, which involved decision support at the point of care. I'll pause if anybody wants to ask a question, make a comment. Okay, I am Bostonian, so I apologize if I'm talking too fast. Feel free at any time to interrupt. So we moved on to our claims-based work, and all of this work takes place in the Medicare context. All the work that we're going to talk about for Cascades, although we've looked at commercial insurance claims for low-value care as well. And one of the sets of recommendations that appears on a number of Choosing Wisely lists is around testing, preoperative testing for very low-risk surgeries and low risk patients. And one of these is cataract surgery, which is a very common surgery. It may well be the most common surgery in Medicare. It's very common, very low risk, a short duration procedure. And there's good evidence showing that routine preoperative testing for low risk patients, patients who do not already have cardiovascular disease, do not benefit from EKGs preoperatively. So we looked at preoperative EKGs and we found in other data for all patients, about 1 in 4 cardiac surgeries begin with preoperative EKGs. And in our data, we were very conservative about weeding out patients that could be high risk, could be deemed high risk. And again, in the guidelines, there are always little clauses at the end that say, unless other risk factors are present, and of course the clinicians have to decide which of those risk factors are relevant. So we took a very conservative approach. We took Medicare beneficiaries over 65. So those are people who qualify for Medicare on the basis of age rather than on disability or another illness. And we compared those who got EKGs before their cataract surgery versus those who didn't, and looked at what happened in the 90 days after their cataract surgery. And we used the 12 months before the surgery as the look back period to identify risk factors that might plausibly make that patient not be low value in terms of the EKG. And so we found in this population where we've weeded out the higher risk patients that about 11% of Medicare beneficiaries who get cataract surgery get a preoperative EKG. So a preoperative EKG that appears to be low value and our best ability to tell. And you know, there were pretty significant differences in a number of patient characteristics. The patients in general had more comorbidities, even if these weren't specific risk factors in this instance. So the Elix-Hauser condition count just means patients who got the EKG were more likely to have other kinds of health conditions present. Patients were more likely to be older. And they were in areas that had a higher prevalence of cardiologists. So there's, as many of you no doubt know, there is a fairly large body of evidence over the last, 50 years about supplier-induced demand in healthcare. And it's been shown generally that when you have more cardiologists per capita, you get more cardiac testing, more cardiac surgery if you have more cardiac surgeons per capita. And while there's a fair amount of debate about how big the effects are, I think it's a fairly settled question in health economics that this kind of inducement does happen. And so we find evidence of a similar pattern here, which suggests, again, that there may be some care that is financially motivated rather than motivated by the clinical characteristics of the patient. And then when we looked what flowed from those EKGs, about 16% of those low value EKGs resulted in some kind of cascade event. And in this study, Ashani and our other clinicians on the study looked very carefully at subsequent tests and treatments to identify those that logically clinically flowed from the EKG. And for the most part, the cascade looked like more testing as opposed to more intensive interventions. And so for every 100 EKG recipients, there were 5 to 11 cascade events in that 90-day period. So they're not rare, but they're not overwhelmingly common. And sort of interestingly, again, most of these additional tests are not the most expensive kinds of tests or treatments. They're more things like stress tests, in some cases, angiograms, catheterization, additional visits. They add up, however, to sorry, I'm looking at the time, they add up to significant multiples relative to the cost of the initial EKG. And so this is one of the questions that we had is, if the low value care itself is relatively inexpensive, does that give you a good idea about how much impact low value testing has on healthcare spending overall? And we looked at this study, the costs associated with the cascade were significantly, I think the multiple was something like 7-fold the cost of the initial test. And so the cascades, while they were relatively low cost, they still were relatively low cost, even when we included all the cascade events. They essentially inflated the total cost of the EKGs for these cataract patients by about 7-fold. So then we turn to a very different context, which is the annual wellness visit for Medicare beneficiaries. So this is a visit that every Medicare beneficiary can get every year, which doesn't include all of this kind of testing, but is intended to be a place where patients can build rapport with their primary care physician, and essentially patients can be better managed prospectively. But since that annual wellness visit was introduced to Medicare under the Affordable Care Act, there's been concern that it would lead to a lot of additional testing in essentially healthy patients that would lead to higher costs and patient harm. So we looked at these annual wellness visits, and we found actually that the most common routine tests that, again, are not recommended for healthy patients that occurred were EKGs and routine blood and urine testing and thyroid testing. And you can see, 10% or less of patients get at least one of these. And then when we looked at cascades for those tests, we found actually fewer cascades, essentially no evidence of a cascade after a thyroid test, and relatively rare cascades that occurred after the EKG and the routine lab testing. And moreover, when we looked at the cost of these cascades following annual wellness visits, they were a fraction of the cost of the initial test. So suggesting when we get these low value tests in very healthy populations, the cascades may not have the same kind of momentum they have in the patients who are undergoing care, even though the surgery that we looked at previously is for relatively low risk patients, a relatively low risk procedure. Those were still patients that were more complex. And so these tests were more likely to lead to cascades of other tests and interventions because patients were more likely to have some kind of result, whether it was ultimately deemed to be meaningful clinically. Another set of studies was really looking at looking at testing that is refined. So there were two different kinds of tests that we examined to look at their impact on cascades. And in both cases, the tests were more sensitive than previous tests were. So the first one is looking at breast screening using MRI versus the standard mammography. MRI screening is much more sensitive. It will pick up more actual cancer and also more incidental results. And so in the case of breast MRI, there is no definitive evidence that it increases survival, but it clearly leads to more findings. It is more sensitive, but it's not clear whether it leads to findings that ultimately lead to better treatment, earlier treatment, and save lives and save morbidity. And breast MRIs are more expensive than standard mammograms. And for this study, we used commercial claims data and what used to be IBM market scan data. I think it's called something different now. And we looked again at a matched comparison of patients getting the MRI versus the screening mammogram, matching on all these other patient characteristics to see what happened after these screening tests. And not surprisingly, the MRIs picked up many more findings actually related to the breast, so the mammary findings that related to follow-up, but they also picked up so-called extra mammary findings, so other findings that were not intended to be identified through the use of this test. So these would be incidental findings. And the cascades, again, led to significant additional spending in the case of the mammary findings, an additional $53 million per year. Although for those of you who've studied the US healthcare system, you know, if we're not using the B word, it's a rounding error. But a significant multiplier of the baseline spending for screening. And again, you know, we rely on the clinical trial evidence to say these tests don't provide significant advantages over mammograms. And I think that continues to raise the question on the part of patients and physicians about whether there is a subgroup of higher risk patients who might really benefit from these tests. So the last study I want to tell you about is another advanced testing result. So a new way of looking at a protein that's identified with having a heart attack, a better test that's more sensitive, again, a troponin test was introduced into practice a number of years ago. And people had a similar concern about this very sensitive test, that it might result in a lot of incidental findings, a lot of findings where a patient was not actually having a heart attack. And so in this case, we had the opportunity to study the implementation of this new test in the Mass General Brigham system using electronic health record data. And we could see the hospitals where the new test was introduced in the emergency room versus the emergency rooms that did not have this new, more sensitive test, and see what happened to a matched comparison group of patients who came in with chest pain. So this looks at the cascade events for patients with and without chest pain during the period. So this is a way of understanding the extent to which the new test caused additional cascades as opposed to other factors. And we found that there was a 3% increase in any subsequent testing once this new troponin test was introduced. So a significant finding, not an overwhelming effect. But what was really interesting in this case was the other side of the coin is that better testing, of course, can lead to reduced uncertainty. And in the case of the troponin testing, the existence of this more sensitive test allowed physicians and other clinicians in the emergency department to comfortably send patients home without doing the additional stress test, without doing the additional testing that might have happened because of the uncertainty, and how important it is, of course, to pick up on whether someone is having or had a heart attack. And so this is the other side of the testing interesting coin, that the value of information can be that more information can help rule out some kinds of events and therefore limit testing. So I wanted to show you the other side of these cascades. And so essentially what we've learned is the cascades are quite common. The experience of having incidental findings and the dilemma of what to do about them is reported quite commonly among primary care physicians. And a lot of social and systemic factors seem to influence what happens with those incidental findings, including the nature of resources. I mentioned the finding about rurality being important, but the concentration of subspecialists being important. And so this suggests that while there may be some interventions that target decision support, thinking more systemically is likely to be important here. And I want to leave time for questions. So I think what's so interesting about these cascades is the extent to which they are experienced as a conflict to physicians. And clearly, there is also an important patient component here. We don't really have definitive answers about the extent to which patients understand these cascades and how to navigate this kind of healthcare. I know from my own experience that these situations can be challenging to know what to do. And it can be very hard to communicate low value care. I think a lot of people, when you say these tests are low value, they think, oh, you mean that you don't want to spend money on my healthcare. But of course, these low value measures that we're using are really about the risks and costs to the individual and not just social costs. So this is not strictly about rationing, but actually about care that patients, fully informed patients, would not want for themselves. But we'll see as these interventions get going how much decision support and information matter. Choosing Wisely came with a big patient information campaign as well. And I think it's unclear whether patients have gotten the message about low value care. So I look forward to your questions, your comments, and thank you very much for your attention. Please. Right. Yeah, that's yeah, I think it would be really interesting to do a general, and maybe someone has done this and I'm just not aware of it, a general survey about those are changes that I've experienced too. And I don't, clinicians still feel really conflicted about it. And I find that for most humans, the idea of thinking about things in expectation is not intuitive, right? So I have had an academic GYN who, wanted to really do annual pap smears and said, but what if we found something? And so it's like that after the fact, looking backwards, and the fear of regret. So it would be, you're right, those are instances in the last decade where the US Public Health Task Force in particular has tried to push back some of these screening services, showing that they cause more individual harm than individual good, forgetting about the social costs. But I don't know how successful that has been. There's definitely still overuse of screening tests in the over 65 population, overuse of pap smears and mammograms for sure. But self-breast exams, I wonder how long a change like that requires to be acculturated. But it's interesting because, again, I think a lot of where we've seen the movement has been in relatively low cost things like self-breast exams that they don't hit the delivery system. I think radiologists maybe, less likely to recommend against annual screening in their guidelines, although some of what the radiologists put in their choosing wisely list did actually hit their bottom line. So those are really good points. Yeah, Caitlin. Mm-hmm. Mhm. Yeah, well, we asked ourselves similar questions, and when we looked in the data, the racial disparities go the other direction. So Black populations and Hispanic populations are both less likely to get recommended care and more likely to get low value care. And so the questions around affordability are really important. The extent to which they exacerbate trust in the healthcare system are really important too. And so this is, I think, one of a huge policy challenge is how do you address inequities in underuse and overuse at the same time when you could try to fix one and exacerbate the other. So it's obviously an open area of the patient role in diagnostic testing when patients are reporting symptoms. That's sort of, it's not covered by most of the screening results that we're looking at, as opposed to care for maternal patients, for example. So they're different contexts, but unfortunately the inequities seem to be that low value care is crowding out high value care in some sense, or that they're simultaneously disadvantaging racial and ethnic minority populations.
Folks that are on Zoom.
Oh yeah.
Over 80 people on Zoom.
Hi folks.
And I think we have a
wherever you are,
a question in the chat. So do you mind if
yeah,
I
go for it.
Oh, I thought I could see Zoom on here. There we go. Oh,
Yeah.
okay. Oh, there's the chat. There we go. Oh, maybe not.
Is somebody else on Zoom who could see? I know, is that, even with my glasses on? For chats. Huh, so weird.
Okay. I'm so sorry.
It's okay.
We'll learn how to do the hybrid thing.
Person on Zoom, if you have a question, you can email me.
Yeah. But I know, want to be mindful of time, but I think there was one
Michael?
other question here.
So I'd like to try to understand, and maybe there are studies that have done it, try to disentangle this component of medical malpractice and defensive medicine and that actually contributes to going down the path.
Right. Well, you no doubt know more about this than I do, but there was a point at which I knew the literature better, and at least at that point, 10 or 15 years ago, the evidence on medical malpractice is that it didn't affect unnecessary testing very much. It was a small but significant effect, and those studies, as some of you may know, they're largely identified off of malpractice reform. So when a state puts a cap on malpractice payouts or makes malpractice suits more challenging. Colleagues of ours have studied those, and others have used medical record reviews to try to examine. And it seems like there's a disconnect between what physicians self-report about the extent to which liability drives decision-making versus what those quasi-experimental studies show. And I know that that quasi-experimental research has its own limitations, so I don't entirely know how to reconcile that. I'd be curious, as someone who works in this area, what you think about that. Yeah.
We didn't find substantial differences in malpractice claims.
Yeah.
After the report, we didn't actually see decreases in claims. We saw improvements in both states that really line up with CMS quality control measures. So hospitals were actually getting better over time.
Reducing their risk. Yeah. Yeah, it'd be interesting to look at whether any of this kind of thing changes with malpractice liability as well. But my one takeaway is that liability looms large for physicians, particularly in the high liability specialties like OB/GYNs and others like that. And so it's psychologically significant. Whether it's really differentiating practice is a little bit less clear to me. Yeah.
Thank you so much.
Thank you.
As we end, I just want to say thank you again to Dr. Rosenthal for being here. And I would be remiss to not mention that this installment of Public Health Speaker Series was co-sponsored by the Center for Health Economics and Policy here at WashU, led by our colleagues Tim McBride, Abby Barker, and Leah Kemper in the back. And I just want to thank all of you so much for making this possible too. And if we could give Meredith one more round of applause, thank you so much.